Thank you so much for having me here. These are my disclosures. So in order to present the totality of the CTO-PCI literature over the past year in 8 minutes is next impossible. So I'm not even going to try. But what I will do essentially is try to highlight studies that I think are practice changing, those that have some controversial results, and also highlight new devices, tips, and tricks. So the first thing we're going to start off with is probably one of the most controversial pieces of literature out there, which is the 2021 ACC/HA SKY guidelines. And these guidelines have now downgraded the indication for CTO-PCI from 2A to 2B. Most notably, the guidelines state that CTO-PCI should be done only for refractory angina symptoms on medical therapy and after treatment of all non-CTO lesions. Stephane, I think, is going to be talking about whether or not the guidelines got it right. The second big piece of literature over the past year is the global CTO algorithm. So as we know, there's a multitude of different algorithms used by different providers. So the thought was to create a cohesive global one that captured the essence of the North American hybrid algorithm, that of the Asia-Pacific algorithm, and then also of the European and LATAM algorithms as well. There are 4 notable changes compared to the hybrid algorithm. First, the use of parallel wiring. Second, the use of IVUS as upfront strategies. The third is the removal of ADR as a primary upfront strategy and more as a bailout. Fourth is the fact that there are criterion given for potentially stopping if you're not making progress. And the fifth is stopping with an investment procedure. Now I'm going to talk about a few randomized control trials. The first trial to talk about is the CT-CTO trial, which was conducted in South Korea. 400 patients were randomized in a 1-to-1 fashion to pre-procedural CT compared to just angiography alone. And the outcome, which was technical success, what they found was that there was a 10% increase in crossing the CTO if you used pre-procedural CT compared to angiography alone. And when you looked at it by JCTO scores, it really helped in those that had a JCTO score of 2 or higher. So it didn't really help if your JCTO score was low. The use of CT, however, was not associated with any difference in hard outcomes. Another registry to talk about, this is one of the longest followed registries. In addition to the Open CTO on the Progress Registry, the Canadian Multi-Center Registry published its 10-year results. And what they found is in around 1,600 patients that they followed for over 10 years, patients that underwent CTO revascularization versus those that didn't had a reduction in their all-cause mortality. And even if you underwent CTO revascularization by CABG or PCI, you derived benefit. And if you also looked at the incidence of needing repeat revascularization or hospitalization for ACS, again, it was in favor of CTO revascularization. Another randomized control trial, which was a little controversial, was the COLOR trial. What it did was it randomized patients in a 1-to-1 fashion to either 7 French transfemoral access or 7 French transradial access. And they looked at outcomes of bleeding academic research consortium 2, 3, and 5 bleeding or vascular complications requiring intervention. And they looked at only the primary randomized site. So if you required dual angiography and you used a second site, that was not used as part of the primary analysis. And what they found was that there was nearly 6 times the event rate using transfemoral access compared to transradial without an improvement in procedural success with very little crossover. However, the devil is in the details. So if you actually look at how transfemoral access was done, less than 40% of patients actually underwent ultrasound guidance for their access, and there's no mention of how many patients actually had micropuncture access as well. Moreover, if you look at the MACE at 30 days, there seems to be a trend towards worse in outcomes with transradial access compared to transfemoral access, with all the deaths being only in the transradial arm. Now, in juxtaposition to that study is the Found Blood CTO registry, and this was a registry of 200 patients that were not randomized, but underwent ultrasound guidance compared to angiography guidance for their access. And the primary endpoint was a composite of local hematoma, pseudoaneurysm, retroperitoneal bleed, AV fistula, and a hemoglobin drop of greater than 3 grams per deciliter. And what they found that the ultrasound guidance group obviously had a lower composite endpoint, but it was really driven by local hematoma, not the more concerning bleeding endpoints. But one thing to mention is that by using ultrasound guidance, the patients had a 2-day lower length of stay than if you use fluoroscopy alone. Again, kind of advocates for the fact that we should be using ultrasound guidance. Another study that I want to highlight is the Teleflex CTO study, which was used to try to get FDA indications for multiple Teleflex products. This was led in part by Dr. Karmpaliotis. And one of the things that was found in this trial is that it had amongst the highest technical success rates of any CTO trial. It was 95%. But the procedural success was about 20 percentage points lower. So procedural success was defined as technical success without MACE. And the main reason for that is this trial pre-mandated serial enzyme collection after the procedure. And as a result, a lot of non-clinical MIs were detected, which then dropped the procedural success rate, but it was not associated with any increased rate of death. So when we think about how MIs should be characterized in our CTO trials and all trials in general, given the controversy with the Excel trial and other trials, I think the endpoints for MI should be fairly well established. And so this is a study that came out of FUY, where they had 2,600 patients that underwent CTO-PCI. They had a mortality rate that was around 3.3%. And when they looked at procedural MIs as characterized by troponin elevations versus CKMB elevations, they found that CKMB elevations, particularly greater than or equal to 5 times the upper limit of normal, was associated with mortality. Troponin was not. And then if you looked at 3 different types of definitions, either the 4th universal definition for MI, the Academic Research Consortium 2nd definition, and the SKY definition, the SKY definition was also the only one that was associated with 5-year cardiovascular death. So if we are going to be doing these trials, the definition of MI should really be CKMB greater than 5 times normal or the SKY definition. Now, one of the things with CTO-PCI is that you're obviously invariably going to fail. You're not going to be successful 100% of the time. But is there something worse than failing? And so this trial looked at patients that underwent optimal canalization, those that failed, and those that underwent stenting but had suboptimal results. Either you lost a significant side branch, your TIMI flow was 1 or 2, or you had a residual stenosis that was greater than 30%. And they basically found that if you had suboptimal recanalization, you had a 5-year cardiac death or MI rate that was higher than either of those arms, and it was economically worse. So this sort of points that if you're going to do CTO-PCI, do it appropriately. If you don't think you're going to get an optimal result, do not stent. Now, shifting gears to the non-invasive space. So one of the potential benefits of CTO-PCI that's been espoused is the reduction in ischemic endpoints. And so Paul Knappen and his group basically did a PET study, and they found that the patients that had the greatest reduction in their perfusion defects, particularly if you were able to get their perfusion defects to 0, had the greatest survival from death and MI. And then if you looked at patients that had a hyperemic myocardial blood flow via PET that was completely normalized, they also had the highest survival free of death and MI. So if you are going to do CTO-PCI, you want to try to take away as much of the ischemic territory as humanly possible. This data was actually presented by one of our the prior talks, so I'm just going to bypass this. And then now I'm turning over to a few tips and tricks. So one of the most controversial topics or techniques in CTO-PCI is antegrade fenestration reentry, AFR, which entails dilating a balloon in the subintimal space, creating fenestrations within the subintimal space, connecting to the true lumen, and then using a polymer jacketed wire to reenter into the true lumen. So it usually requires 2 systems. So Galassi et al. Have come up with a device essentially where the balloon as well as the wire can be done on the same sort of system, where a semi-compliant balloon is inflated in the subintimal space, which is on the RX portion, and then there's an over-the-wire port where you can use your reentry wire. This was published in CCI just last week, and what they found was essentially that they had a 71% success rate for the case. They had 14 cases in this case study, case series, 4 of which were with primary upfront usage, 10 of which were with bailout for antegrade failure. Another part that's fairly vexing for CTO PCI operators is when you are able to get into the true lumen of a bifurcation, but there's dissections in both vessels. So what's the best potential stenting strategy? So whatever bifurcation strategy you use, one of the issues is that you can close the bifurcation with a potential dissection flap. So Jabbar et al. From Emory published the double barrel crush stenting technique. In this technique, you basically have wires down into the true lumen, albeit with dissections in both limbs. And what you do is you have stents that are placed in both the side branch as well as the main branch. The side branch stent is brought back to the point where on IVUS, both wires are proximal, are in the true lumen in the proximal portion of the vessel. Both stents are then inflated as a double barrel, essentially. And then what you do is you take a dual lumen microcatheter on the wire in the main branch and you use a stiff angled wire, and then you enter through into the side branch, which you should be able to do because the side branch was inflated and with the stent and is open. And you try to enter at the carina or one of the proximal struts. You can then take that out, do a kissing balloon inflation, and then after you do the kissing balloon inflation, you're going to pot. And that way, you never lose access to the other side branch, and the other side branch is stented. So again, in the interest of time, I'll stop here. What we need is definitive RCT still of hard endpoints. We still don't have that. Ischemia, CTO, and Noble CTO are trials that are ongoing that hopefully will answer that. We obviously need continued innovation, both techniques and tools, to make the procedure safer, quicker, faster. We need to continue to figure out how to reduce MACE rates and complication rates, because we do know that CTO PCI is associated with worse outcomes, at least in the short term, compared to conventional angioplasty and PCI. And the other part is we need analysis around CTO PCI training. So there's multiple ways to learn CTO PCI, but are there ways that are superior to others? So I'll stop there and sort of take any questions and open this up for discussion.
Since we have 2 minutes for discussion, Darsh, so you know me, keep it simple. What's the one study that was the most impactful to you?
I guess the one study for me is essentially, I guess, the Canadian study, their multi-center registry, which was a fairly large registry. It's one of the largest populations out to more than 10 years, and it basically showed a mortality benefit, and it showed that you can reduce ACS admissions. And so for me, it kind of proves that, you know, we may not be able to show hard differences in the short term for CTO PCI, but in the long term, we potentially do have real meaningful benefits that could affect outcomes.
That's awesome. Thanks, Darsh. Just so we keep us on time. Our next speaker is Stephane Rinfret from Emory, who's going to talk to us. Is CTO PCI only indicated for symptomatic improvement?
Thank you very much, and congratulations to the organizer for a great meeting. So to that question, so these are my disclosure. To that question, is CTO PCI only indicated for symptom improvement? I would say no. Because the lack of evidence from randomized trial doesn't mean that there's no other benefits, especially only well-designed and powered RCD can reject strong observational data. And actually, what is evidence-based medicine? What is it not? Right? This is like an old paper from 1996 by very best esteemed epidemiologists. And what they would say is that good doctors use both individual clinical expertise, best available external evidence in making the decision. It's not a cookbook of medicine, and evidence-based medicine is not restricted to randomized trial and meta-analysis. So, and by the way, these are good doctors. An open CTO that did CTO PCI, and you see symptom relief was the majority of cases, but there were other indications for which these doctors took the educated decision to proceed with revascularization. Now, I'll give you 5 other reasons to open CTOs. First, to reduce ischemia, improve tolerance for future events, improve LV function, improve outcomes in post-CABG, and to improve survival. So to reduce ischemia, this is a good study where published a few years ago where they actually took 50 patients with severe lesions and 50% with CTOs. So the CTOs, they cross-deliver an FFR, and they did FFR. So the FFR in the CTO lesions was lower than in the severe lesions, so they're very low, and both benefit as much, so they were invariably ischemic. A very good study recently done by Peter Kayert from Belgium, where they actually use IFR this time. And you can see IFR numbers that you never see, 0.33, and they largely normalize after CTO-PCI. So therefore, they're invariably ischemic. And why ischemia matter? There's a big study. Darshan just discussed a bit about it, but it's Paul Knappen and his group from Amsterdam. They look at the outcome of patients following CTO-PCI, whether they had residual perfusion defect or not. And actually, if you could not reduce the ischemia, their outcome was not as good as if you could reduce ischemia. So that has a very important consequence. And if you look at appropriate use criteria, actually, if you look at just the asymptomatic patient, it's rarely, like we used to say, inappropriate to do one vessel PCI, especially if you have intermediate, high risk, FFR is low, whatever. Most of the time, they'll say it's maybe appropriate to do it. So that's the reason why I'm very concerned about those guidelines. I've never believed in guidelines. And I think in the end, those guidelines are fundamentally wrong. And as doctors, we have to use the best data. So to improve tolerance to future events, you know that interdependence concept or double jeopardy. If you have 3 coronaries and one is dependent on the other, if you block this one, that's going to be a problem. So we know that these patients, when they have a CTO and they present with an AMI, they have a much higher mortality. That's been replicated in many studies. So this group from the Netherlands decided to say, we're going to just try to prove this in a randomized trial. So they took the survivors in Explore trial and they say, we're going to open up their CTOs now that they've survived their STEMI, and we're going to see if the EF at 4 months will be better with CTO-PCI. Guess what? They didn't find any difference. So I would say that with a small sample and no evaluation of ischemia and that strange of a hypothesis, I'm not that surprised that you would have a negative trial, especially if you're big in the middle of the MI, post-MI remodeling period. So I don't think that this clears the question of improving tolerance to future events, not at all. Can we improve LV function? Yes. A big observational study from 3 large centers looked at the effect on LV ejection fraction. When they looked at the patient who had low EF, 35 and lower, there were a 43% improvement in LV EF in patients who had low EF to start. And this is a meta-analysis by Michael Megali and obviously Manos, where they looked at 34 observational studies. On average, when you do CTO-PCI, you'll gain about 3.8 to 4 points of ejection fraction, whereas the LV systolic volume will be decreased by 4 milliliters. There was a randomized trial done by my friend Kembis Mashaiki, where actually his objective was to try to find if CTO-PCI would improve regional motion contraction, and it did not. And there was no difference if you would do non-CTO-PCI only or if you would fix the CTO over doing also the CTO-PCI in 184 patients with normal EF. So what it says, well, it's the limitation of that study, is that the effect of CTO-PCI on regional motion is likely diluted when you're doing non-CTO patients because you improve the flow through collateral, and it cannot be generalized to patients with low EF. So what we know with low EF remains what we've derived from observational studies. Can we improve patient post-CABG? Of course. Prevalence of CTOs post-CABG is up to 50%. Why is that? CABG caused CTO. And it's more prevalent when you have a severe stenosis. It's not about any progression of natural progression of disease. It's caused by the competitive flow in the artery. And we know that once the graft is down or failing, treating the native coronary disease will be much better than treating SVG. This is observational data, but it's 10,000 patients where we show that, where Manos showed that in ACC and CDR that treating a native is better. So therefore, just an example here. It's a non-STEMI, 65-year-old post-cabbage, TIMI2 flow in the PLV. I mean, it's not really a CTO case. It's like a slow flow in a PLV, but I have to deal with this CTO if I want to improve that PLV. We did the reverse cart and then an ADR, and we reopened this, and we restored, left that SVG on the PDA, and now the right is filling the PLV. So where does it fit into it? Well, that's still CTO PCI, but I'm not doing it for quality of life. I'm doing it for art event. He's having a non-STEMI, and that's the cause. Here, if you look at actually in the appropriateness criteria in the IMA, if the IMA is patent without significant disease, and you've got either SVG or native disease, there's rarely a single case where it's rarely appropriate. Most of the time, what you'll be doing will be either moderately appropriate or clearly appropriate. What about improving survival? I want to remind you that non-CTO PCI does not improve survival. However, in the most recent meta-analysis and all the ones we've done so far, there's a consistent reduction in mortality. It's not even heterogeneous. It's 48% reduction in mortality. Look at MI. MI, it's all over the place. I don't believe that opening a CTO reduces MI because it's already closed. But opening a CTO can reduce your mortality. So decision CTO has been talked a lot. The randomized patient to CTO PCI or not. Primary endpoint was a composite because you need to do a smaller trial. So you composite death, MI, stroke, any revasc. So therefore, you dilute the real important endpoints. They ended up randomizing 2/3 of their sample size, and they had a high crossover. They didn't find any difference. The study showed similar rates of death, MI. But if you look, the devil's in the detail. Look at the cardiac mortality, 1.9 versus 3.4. This is a 44% reduction in mortality, exactly like in the meta-analysis of observational data. When you look at peri-procedural MI, that's what's driving it, a bit more with CTO PCI. Funny enough, stroke does not seem to be caused more by CTO PCI. At least it's numerically lower. So what is this effect on mortality in that trial? Is it the better error, which is insufficient power? Well, probably, because the long-term mortality was 1.9 with complete revascularization and 3.5 with non-CTO PCI only. Its 44% reduction in mortality is exactly the same as in the observational data. If you would like to do a trial power to detect such a large effect, because it's a large effect, 44% relative reduction, you would require 3,000 patients. Let's say you're more modest, because when you design a trial, you always say, I'm going to reduce my events by 30%, okay? Well, we raised to 8,000 patients. Well, Decision CTO took 6 years to recruit 1/10 of that sample. So looking important, if you're going to have a confirmation that CTO can reduce mortality, we'll never have that from a randomized trial. In that very nice study done by Brad Strauss from the long-term Canadian CTO registry, look at the mortality. It's driven by PCI of the CTO or cabbage of the CTO. So there's a consistent message, revascularization. So if you do cabbage to non-CTO only or PCI to non-CTO, you do the same as a medical therapy. It's only if you get CTO revascularized, either with cabbage or PCI, then you get the impact on mortality. So in my conclusion is that strong observational data support the benefits of CTO PCI on top of improvements of symptoms. There are 2 small randomized studies that did not address the real question, and the best observational data prevail as best evidence to inform medical decision. So in conclusion, opening CTO reduces ischemia because collateral cannot provide sufficient flow during stress. Although CTO don't cause MI, the presence of a CTO decreases tolerance for future events. CTO PCI can improve global LV function if your EF is too low, is low. CTO PCI is a necessary alternative to SVG PCI or redo cabbage. If you say that we don't need CTO PCI, well, there's a lot of post-cabbage that will have a hard time. And CTO PCI may be the only non-STEMI indication or lesion subset where PCI improves survival. So data on mortality from RCT will probably always lack. And the best evidence medicine to date is from numerous observational studies. And I would say that the lack of randomized trial does not mean that we have lack of evidence or biological plausibility. So thank you very much for your attention.
That was an excellent presentation, and Stephane, you were very clear that you don't believe in guidelines. However, I want to open it to the panel and get some opinions. Did your practice change, or you're thinking about opening CTO, PCI, or evaluating patients after the recently updated guidelines? Anybody from the table, or even two?
Actually, no. The answer is no. I mean, these patients came to us for symptomatic relief. They have several different symptoms: fatigue, dyspnea, angina. They need answers. They want to improve their quality of life. So, you know, I agree with Stephane. Particularly, these latest guidelines do not give the right message to us and to the patient. And I think we should do better studies perhaps in the future, but for sure we should not stop providing symptomatic relief to the patient. And as Stephane also pointed out, there might be additional benefits, particularly on hard endpoints that unfortunately a randomized trial will never be able to prove, such as mortality. And I think we should do better research in this field for sure, but CTO-PCI is the way to go for improving patient quality of life and possibly other outcomes.
I would echo that. It hasn't really changed my practice at all either. The main reason I do it is for symptom relief, but there are other reasons other than symptom relief where I'll go after and do a CTO. I guess what I would say is that if you're going to do something like that and try to demonstrate that there's a mortality benefit, you have to be successful doing it. You can't fail, right? If you fail, we all know that the MACE is 2 to 3 times higher than if you just leave them alone. So you have to be successful doing it. But it hasn't changed my practice pattern at all.
Can I say something?
Yes.
Dimitri, it's Cal Swad. So
I know.
Thank you.
Nice to meet you.
Nice to meet you, Dimitri. Very nice. So listen, the guidelines did not change our practice in your centers and in my centers, and probably our sample is skewed a little bit. But what the guidelines did, we can actually, the people who practice in the trenches every day are not in UW or Morristown or these big centers. They have to make decisions about their patient, and I think the message is clear. If the patient is symptomatic, you have to do something about it, and if you cannot do it in your center. But also the guidelines now give ammunition. Well, if the patient is asymptomatic, normal EF, and does not have non-STEMI because of, believe it or not, CTO does cause non-STEMIs, although people are surprised, then you can actually wait. And 38% of the time, according to the COURAGE trials, and hopefully the ischemia trial will show that too, that at the end of the day, the patient need the artery open because of events down the road. And don't forget, we still prevented spontaneous MI in the ischemia trial, right? We did not, it was the washout for the MI because the procedure caused pre-procedure MI. So the guidelines, I'm not going to bash the guidelines that much, but the guidelines is based on available data, and available data based on available interventional cardiologists, and available interventional cardiologists do not really do a good job performing complete revascularization and trash in, trash out.
I like your editorial.
I'll make it simple. The only place you see guidelines used are in the courtroom. So in the courtroom, 40% of class 1 indication guideline indicated anything, whether it's beta blockers in heart failure, statins post-MI, pick whatever you want, don't get done. It's not people in the trenches, we just don't do a very good job. And mostly it's because people don't respect the guidelines, because we have a bunch of people praying at the double-blind randomized placebo-controlled trial, which is great for drugs, but not for procedures. You can't do a trial of something you can't do.
Yeah, no, I think, oh, sorry.
Just to complete the thought, the guidelines aren't validated. They're retrospective analysis of data that's been done. The appropriate use criteria have been validated. And it shows that if you follow the AUC, If you do a PCI or a surgery in someone rarely appropriate, it causes harm. If you do not do PCI or CABG in someone who is uncertain or is appropriate, then you also cause harm. So I would just say is, if you're going to cath someone, make sure they have an uncertain appropriate indication. If they do, and you don't fix it, it's not an indication problem. It's a you problem, because you aren't good enough to manage the lesions, and that's okay. It just means you need to figure out how to get better at your job to do what the patient needs.
You know, I would echo what you said. You know, I think what you have also to do is to document. I had like a case recently referred to me, 50-year-old with an LAD CTO. The guy is barely symptomatic, but he's referred from the general cardiologist saying he's got a huge area of ischemia. And he's 50, and I think we're going to send this guy either for an IMA or a CTO PCI. And I said, like, the guy was not happy with the idea of having an artery blocked and everything. And I clearly documented in the note that although the randomized trial are lacking, there's observational data to show that it might be a better option, and we all agreed together with the patient and the treating physician that it would be the best way to do it. And he accepts the risk and everything that would be higher on the short term, and maybe so to pay maybe a higher price for a higher longevity. So I think there's a way to get to still support your thinking in a chart the right way, but you have to document, you have to write. You have to, so that's what I've learned in Canada, and I'm still using it here.
All right, thank you. To keep us on time, our next speaker, Ashish, are you hiding in here somewhere? Manos looks like Ashish. Ashish is Manos? Yeah. Excellent. We're going to get an upgrade here.
Ashish, you lost weight.
CTO PCI is bad. Actually, cricket is worse because Ashish got cricket accident and apparently he's broke his nose and cannot be here with us today. So we sorry, feel bad for him.
He broke his nose playing cricket.
So please don't play cricket, okay? At least before this meeting. After the meeting you can, but before don't. That will come with the faculty instructions for next year. But in any case, so I guess you were stuck with me. So this was Ashish's talk, which was about CTO crossing algorithms. He have reached an agreement. And this is something you already heard from people. And as you know, we do have new nomenclature now with the CTR document. We call them extra plaque, not subintimal anymore. And we do have 4 ways to cross a lesion. There are 2 antegrade wiring, antegrade dissection reentry, and the same thing for the retrograde wiring and retrograde dissection reentry. And the more complex the lesion, the more likely you are to need the retrograde and ADR than if you have the simpler ones. But at the same time, there's always this caveat that the more advanced techniques you use, like ADR and retrograde, then the risk goes up, which again might be because of the technique or because what you are using it on is a much higher subgroup risk to start with. So this was the first algorithm. A lot of people on the panel created this. And that was the hybrid algorithm, trying to put some order on how you approach CTO, starting with dual injections, and then based on the analysis of the angiogram, deciding antegrade, retrograde, and of course, having the change, which is one of the mainstays. This evolved later on. There was the Asia Pacific, which is very similar, adds the parallel wiring, the IVUS guiding puncture of the proximal cap, and very similar for the Euro CTO club as well. That I know essentially the basic tenets are the same. So based on this, there was an effort a couple of years ago to try to merge all of them into one algorithm that can kind of be globally accepted as a blueprint, having, of course, differences in the local parts. And this is the so-called global CTO crossing algorithm. It's in JAC, and this is a summary. These are 10 steps that I think do have a kind of broad appeal. So what's the first 2 steps? The first 2 steps are dual injection and a careful review of the angiogram. Dual injection remains one of the most underused tools for CTO PCI, especially at non-CTO centers. I'll be amazed how often you see films from people who do CTO PCI without dual injection, but that's critical for the success and the safety of the procedure. Donor vessel first, wait a couple of seconds to the second vessel. Again, simplest way to increase your success, decrease your complication rate. Then, after you do this injection, you have to look at it. And look at it is not just like a quick glance, but actually spend enough time, 10, 15 minutes, 30 minutes, as long as you can. Because again, what you see early on is different than what you understand the more you look into this. And you look at this in a structural way, where the lesion starts, the proximal cap, the occlusion length, the distal vessel, and the various collaterals. You can use various scores like the JCTO, which is the most commonly used, which actually give you a sense, especially early on how difficult this lesion might be and help you avoid getting these very complex lesions early on your cath lab schedule where your chance of success are fairly low. Progress CTO score along the same lines as well. You want to start with the simpler lesions and then go to the more complex later on once you're more experienced. Many people now use more coronary CTA, and I think CTA is having an impact, especially for more complex lesions. If you can see very well the distal vessel, CTA can be very useful. Actually, in a study, it was more accurate in predicting success than the angiogram itself. Example of easy lesion, nice tapered cap, soft, no calcium. Another disaster here where you have a very long occlusion length, calcification throughout side branches at cap. This was a failed case. Moving on, what is the first thing you look after the angiogram is the proximal cap. Do you understand where the CTO starts or not? And if you don't, there are different ways to, as we say, resolve the ambiguity, which are the retrograde approach, use IVUS guidance, or use the dissection re-entry, move the cap techniques. So these are summarized here. Sometimes you may not be able to resolve the ambiguity, you go retrograde. But quite often, if you look at the angiogram in a more detailed way, if you do an IVUS on a side branch next to the proximal cap, or if you use the move the cap techniques, you may be able to resolve the problem and cross through the lesion. This is an example of the RCA CTO. There's a side branch at the proximal cap. It's really hard to know where the lesion actually starts. And then you have to find your way, use different techniques to figure it out. The next thing you focus on is the distal vessel. Do you have a good quality, meaning a large distal vessel free of significant diffuse disease? If you have that, that makes your life easier. And then the fifth parameter here is whether you have the so-called retrograde crossing option. We used to say, do you have interventional collaterals? But the bypass grafts are not really a collateral. So just for terminology purposes, the term retrograde crossing option became available. The bypasses and the septals are the preferred ones. Epicardia are a little more complex, but can be done in several cases by experienced operators as well. Step number 6 is antegrade wiring. So if you have no ambiguity, you have nice big distal vessel, then you're going to start with antegrade approach. And antegrade wiring is the most commonly used and the staple of CTO PCI. And actually success has been going up with new equipment, new wires and microcatheters. If it doesn't work, you have different antegrade crossing attempts. One is the parallel wiring, the other is the ADR. I know some people on the panel are allergic to parallel wiring, but we'll discuss this later on. But again, these are options and depends on your experience. If you're, if you have experience, this can work. Europeans, Asians do it. They can be longer procedures, something to be taken into account, but there are different ways to get this done properly. ADR has been traditionally what is done in the US more commonly if you have sub or extra plaque wire position, with the Stingray being the main frame, and Stingray-based re-entry has been very useful. Moving on to the retrograde, as we say, there is several steps for doing this. It is a powerful technique, although it does have some risk. The reality is, many of the highly complex cases, this is often the only way to get it done. So if you want to be a high-end experienced CT operator, you have to have retrograde under your belt. And then be also able to deal with the potential complications. Systematic approach, step by step, can come a long way. Step number 8 is to change the strategy. And that's something that you hear from everyone. I think everyone agrees on this. We used to try something for 20, 30, 40 minutes. Now a sign of experience is to know when to stop doing that. The faster you realize it's not going to work, the better it's going to be because you save radiation, you save contrast, and you increase, as a result, your chance of being successful and decrease your risk of complications. The initial approach is hard to see on the slide, but about 50 to 60% is successful. You need the second, third type of crossing attempt to be able to get to the 85, 90% success. Number 9 is an investment. That's an umbrella for different ways to approach a CTO. So another way, if you have inability to cross the lesion, you end up being extra plaque. What you can often do is use the STAR technique, which is taking a polymer jacket wire, knuckle it all the way to the distal brand, restore antegrade flow, but don't put a stent, just let the patient recover, bring them back after 2 months, and then quite often your wire is going to be much easier to advance to the distal true lumen and then be able to stent at that time. So STAR, but start without the stents, and then bring the patient back a couple of months. That works very well for many lesions. And then finally, when do you stop? There are 5 reasons to stop. One is if the duration of the procedure is very long. 3 hours is kind of a cutoff if you haven't achieved much progress after this period of time. The other one is if you use too much radiation, with 5 gray being the usual cutoff. Third, if you use too much dye. 3 times GFR, especially if you're having a patient with baseline CKD. Fourth, if you have a complication, unless proceeding is going to help you deal with the complication. And fifth, if you've done everything you can think of and it hasn't worked, then you have to stop and try things that may not be safe or appropriate things to do. Complications remain one of the things to be particularly careful in CTO-PCI, which does carry increased risk of complications with other procedures. So doing this, you're going to be very careful, monitor the patient continually, look at the EKG, look at the pressure. So if something were to go wrong, you have a perforation, you have a dissection, then you can take care of it right away. So again, 10 steps, global CTO crossing algorithm, you can read it on Jack. And I think gives you a framework. You don't have to follow the steps verbatim. This is a blueprint, gives you a way to think about CTOs, and the more experience you get, then the more often you're going to deviate from this. But again, that helps you create this frame of mind that can help you be successful and safe in your procedures. Thank you so much.
So, excellent, Manos. Actually, I think the title of your talk is Have We Finally Agreed on an Algorithm? And a lot of us have our names on that paper from all over the world, but you go to several meetings and people still do whatever comes to their mind. So have we actually agreed on an algorithm, or is it still the operator?
Well, agreeing on an algorithm is one thing. Doing it is another thing. So I think the algorithm is kind of accepted, but I must tell you, I mean, most places, most people, and I think it depends on the stress and the level of experience, right? I mean, some people deviate from the algorithm, and actually the intent of the algorithm is not to be 100% conformity, right? The goal is not to have everyone do the same thing. The goal is to have a frame of mind, and you know, then you can, the more experienced you are, I think the more often you're going to deviate.
Any other questions, Stephane?
You know, when we go to meetings and stuff, you see, I think the big variation in the practice around the world is the comfort in using the extra plaque or subintimal space as a mode of treatment, either, you know, to go for knuckles right away, to instead of trying to stay intraplaque, to convert to star right away and bring back the patient. Everything is just, this is more Western and North American big time. You'll see in Europe and in Asia, contemporary reverse cart operators staying like 2 hours and trying to stick a 1.5 balloon because they're still caring for creating large dissections. And this thing has never been solved. So you will not get Asia Pacific to sort of accept that using the subintimal space or stenting the subintimal space leads to similar outcome. There's still a big resistance there. And I would like to hear what you think. Have you seen this? And what can we do to sort of slack this a bit and maybe come to a better agreement over time?
Well, maybe I'll let other people answer this question. But I agree with you. I mean, the variation in practice is real. It is, I mean, we were meeting recently and it was Antegrade wiring for like 3 hours. I mean, you know, there comes a point in life where, I mean, it's clearly not going to work and you have to move on. But the threshold for that component of change, I don't think has completely, it's not on the mind of people have a different threshold of wanting to change. So for me, if you're at 8 gray, I mean, you're done. I mean, there's nothing you can do. I mean, you've exceeded, it's a safety issue anymore. But in some countries, this may not quite be there for various reasons.
And I would also add that, you know, now there's data. There were observational studies, national registry, the British registry, multi-center registry that you and I and others, and now also consistent CTO, which was a prospective and rigorous single-arm trial, and also a German study, I think, from Munich that they did follow-up on subintimal techniques versus non-subintimal, like a true-to-true approach with OCT. The data is there. There are no differences in clinical endpoints. Still, many people are on the other side of the world are not convinced by that. So I don't know what else it takes at this point.
Maybe we can ask Kate. I mean, you know, Kate is less biased on this. I mean, what is your take on the variability versus following a specific algorithm?
Yeah, I mean, I think sort of watching this without a lot of skin in the game early on, I found that really confusing, and that practice heterogeneity at great meetings like CTO Summit where you see that, but it does seem like it's more of a faith-based argument at this point than a data one. So I think it's more of like what people are trained to do, what they're most comfortable with, and maybe being uncomfortable with the alternatives. You know, certainly, as you mentioned, experienced operators might try much harder with one strategy in a certain case because they think the retrograde option is very risky or something like that. So I think, you know, hopefully by continuing to do this, we can become more comfortable with each other's approaches, because I think we can learn from that too. But it does seem like it's less of a data issue and more of a belief.
And we did a study back with Darshan and Song when I was at Columbia, and we did both acute outcomes. And the most important finding, which was consistent with the British data, is that there's no real-time way of knowing exactly where you are. So essentially, you may think you're doing intraplaque wiring, but in the vast majority, in a good majority of cases, you are extraplaque. Especially if you do retrograde wiring, then most of the time, by definition, you're going to be extraplaque. And the most interesting thing is that if you try to intentionally knuckle and get extra plaque, in a significant number of cases, you stay within the plaque. The only difference, and correct me if I'm wrong, Darshan, was we had a slightly higher incidence of periprocedural MIs due to small branches occlusion, but at 1 year there was no difference in the overall outcome because we had a follow-up paper as well. So I still don't think why. I agree with you. I don't understand why people are so afraid of the subintimal space.
And you know what? The issue is that this is fundamental because that drives all the other decisions. Because the insistence of wanting to stay plaque will drive operators, because you see the wire diverting into extra plaque subintimal, and then right away in their mind is that the only way to solve this will be to go retrograde. Oh, we've got an epicardial, but we're able to do it and everything. So the whole thing is that this drives a lot of, I think, behavior as operators that might not be the safest way to deal with the case. And that's something that needs to be sort of challenged at some point, is that when because your insistence of staying intraplaque, does it justify you to go and take higher risk approach?
I think this is a very interesting discussion, probably above the room's thing as a more political event, and we've got to stay on schedule. So, Manos, thank you for sharing that. I think what you can see is maybe there's not as much consensus as we might all hope. And with that, I'd love to learn more about Antegrade, CTO crossing tips and tricks from our colleague Jay Khatri from the Cleveland Clinic. Jay?
Great, thank you so much. So the talk I'm going to present is maybe to try to understand how a North American operator can adopt some of the principles that are being shared by this global crossing algorithm. And part of that is maybe being a little bit more comfortable with Antegrade wiring. And I'll share some tips that I've learned along the way. So the global algorithm, I think that the biggest shift would be this idea that from the original hybrid algorithm, there was a decision-making point based on whether the lesion is 20 millimeters or longer. And that would help you decide whether you were going to do ADR, go retrograde, or whether you could do Antegrade or not. But the argument could be made that maybe it's not 20 millimeters long. And you can use wires potentially to shorten that distance. And you can use IVUS to help shorten that distance. And you can use parallel wires to help shorten that distance. And that's what I hope to share with the audience today. I group wires for Antegrade into 3 categories. So there's intraplaque or extraplaque jacketed wires. So these wires are really meant to find the path of least resistance. You're not wiring anything. You're introducing these jacketed wires to the plaque, and then the wire is finding the path of least resistance. This may be intraplaque, this may be extraplaque. It's sort of irrelevant. It's finding the path of least resistance. That's its job. And then you have to move on from there depending on how the wire responds. I put a bunch of different examples in the right column only because there's a whole slew of wires that are available for this. there's taper wires, there's stiff wires, but they're all jacketed, they have no tactile feedback, and they find the path of least resistance. Some are designed to knuckle, some are not meant to knuckle, but the point is they're slippery and you can't feel, and they find the path of least resistance. The second classification wire is the steerable wire. Now this is a wire that's meant to provide tactile feedback so that you can direct it. And the idea with these wires is generally you use your first wire to go wherever it's going to go, and then you use the steerable wire to hopefully redirect away from where you've deflected off course. These have tactile feedback, and you can actually feel what the wire is doing in your fingertips. And so the wires that we use most commonly are the Gaia series wire. I think that they're very, very useful for this purpose. And then the last wire is the penetration wire. And these are typically just to make a hole. And after that, you're done with these wires. You don't really use these wires for antegrade wire escalation other than to make a hole, and it's often done in conjunction with IVUS guidance. So those are the three categories of wires. There's a bunch of different examples, and depending on where you work and your lab and what country you're in, you may have some wires that are available and others that are not. We have a lot of supply chain constraints because of the current health issues, and so we kind of just pick whatever wire is available in these three categories. So this is an example of using a soft jacketed wire just to probe the cap. And you can see in the left panel, maybe a little overcommitted with the microcatheter. There's no tactile feedback with this wire, but you can see it buckling. That means that it's hitting something that it's never going to penetrate. Pull the microcatheter back a little bit and just reintroduce the wire, and it found the path of least resistance. Now, I don't care if this is luminal or not. In this case, it was luminal, but the whole point of this wire is to see if there is a path of least resistance. Is there a microchannel? Can I get subintimal? It's sort of irrelevant, but there's no tactile feedback with it. All you're doing is looking at the fluoroscopic behavior of the wire, and then you move on to the next step. So this is an example of left main CTO that I did, where the soft jacketed wire very quickly became extra plaque, and you can see that in the left panel that we have deflected off course. And that's fine. So people might panic here, but this is actually not a problem. Now you've identified the course of the left main, you know where the wire has deflected off course. Now you take a steerable wire and just use it to drive away from where you've deflected off course. You can see in the right panel, we use the Gaia series wire to on purpose drive away from where we feel we veered off course with the jacketed wire, and we very quickly re-enter the true lumen distally. So this is sort of an example of using that high tactile feedback steerable wire to correct the problem of the deflected soft wire. So what about a case like this? This is a patient who had a complex circumflex CTO with no retrograde options and no really good landing zone for an ADR. I really like to share this case because this was done by one of my fellows maybe a month before they graduated, and it wasn't done with me, it was done with a different attending. I'm showing you this just to point out that this can be learned very quickly, and I think it is something that is important to try to master as you do these cases where there may not be other options. So in this case, once again, we did the same thing. We take a jacketed wire, introduce it into the plaque, and we very quickly start spiraling around the vessel. But that's not the problem. We've actually solved the ambiguity of the course of this vessel because now we know exactly where the circumflex is. And if you look in the right panel, you can see where there's contrast to the left of that wire that spiraled around the circumflex. So now we know exactly where to put a steerable wire. So in the next set of slides, you'll see my fellow took a Gaia 2 wire and on purpose is driving it towards the areas where we think that the jacketed wire is deflected off course. And you can see with just a little bit of patience, a little bit of redirection of this wire, he was very quickly able to re-enter the distal true lumen and got a very nice result. But it took this understanding that the first wire, once it gets extra plaque, that's not a problem, that's not a complication, that's an opportunity to correct the crossing. Well, what about more complex cases? When do you use penetration wire? So this is a very complex proximal cap of an RCA. This is a case that, it's really hard to know how to access the proximal cap. And the only way you can do this is with IVUS guidance. And IVUS can tremendously improve the likelihood of puncturing intraplaque. And puncturing with a penetration wire intraplaque is the key to getting an antegrade case done, whether it be an intraplaque crossing or an extraplaque crossing. The next step is to get a jacketed wire down the artery so that you can either re-enter by star or spontaneous re-entry or do a stingray re-entry, but you have to puncture intraplaque to have this happen. And that's what the IVUS verifies. And so the next step was to take a jacketed wire. In this case, we took a jacketed Mongo, which is designed to prolapse, and it was meant to set up an ADR case, but it spontaneously re-entered, and we finished this case without having to do anything. But what set this up was to intentionally use an IVUS-guided puncture to start the case out. What about cases of investment procedures? This is a patient that we tried Antegrade, Retrograde, could not get the case done, could not do ADR, brought them back after an investment procedure, and when we brought them back, patient had a persistent dissection flap from our investment. We used the IVUS, again, to identify where there may be some plaque to puncture, use that to direct a puncture wire into that plaque, and actually, once we put a jacketed wire back in here, we were able to enter the true lumen distally without having to do anything too fancy. So don't forget about using IVUS to improve the likelihood of success of your antegrade wiring. So in conclusion, I would tell you that soft jacketed wires are a great way to start a CTO because you may be surprised at how quickly a 20+ millimeter CTO is nothing more than a 2 or 3 millimeter CTO just by introducing this jacketed wire into the path of least resistance. And there are very low complication rates by doing this. It's a great way to start in the beginning when you're not well-versed with all the other crossing strategies. I think that it's a good way to set up for more advanced crossing strategies as well. And then the last thing I would want to share with you is that antegrade wire isolation can be tremendously improved if you use IVUS guidance and the judicious application of more specialized wires, particularly steerable wires and the penetration wires.
That's a great talk. So Paul, this often comes up and listen to this talk, I think I get a sense, but should every case start with antegrade wire?
Unless it's flush occluded right, I think every case should probably start with the antegrade wire.
Okay. Jason?
I would say no, not necessarily. I think oftentimes having retrograde gear in can help define the course of the vessel, which makes antegrade cap puncture safer. And so I think if there's no ambiguity on the proximal cap, and you don't have a marked degree of tortuosity where you'd be really worried about the true vessel course, those are cases where, yeah, I think it's very reasonable to start antegrade first. But there's a fair number, probably 5 to 10% of cases easily where you really want to go retrograde just to help define your course.
How about you, Jay? You gave the talk. Do you think every case ought to start antegrade?
No, absolutely not. I think that the whole idea here is how can you efficiently and reliably resolve ambiguity to cross safely. And sometimes you can do that antegrade, but oftentimes there are situations where that's more complicated. It's actually easier to cross a septal and get gear retrograde to have a target. It all depends. You have to be flexible.
This has come up in a recent discussion, so I'll ask Dimitri, which is safer, a Gaia 2 next antegrade or going through a septal retrograde?
Septal retrograde.
Lorenzo, what do you think?
Well, it highly depends. I think in general, retrograde through septa is a safe approach, but still it can entail its own challenges. One thing is that if antegradely you need a Gaia next third to just pierce the proximal cap and the occlusion is maybe 10 millimeter long. The other thing is the occlusion is 60 millimeter long. There is a lot of calcium tortuosity. So what's the purpose? Maybe you can pierce through the proximal cap and advance intraplaque 5 millimeters, but then you're going to exit the vessel. So I think it needs to be a personalized discussion in each case, but as long as the operator is facile with the retrograde techniques, there's nothing wrong in going retrograde through a septal. Different stories with epicardials, of course.
All right, that's a great talk. Appreciate it, Jay. Thank you so much. To keep us on time, I will introduce from Morristown, Dimitri Karmpaliotis, the famous Gigi, who is one of the founding CTO operators in the country and certainly one of the experts.
Thank you, Bill, and thanks the organizers for inviting me. Actually, a lot of the things that we talked about, antegrade, retrograde, what's safer, will come up in the case that I'm going to show you. These are my disclosures. So pretty much this is a sketch that Bill drew 14 years ago, but not much has changed since. And this is what happens in retrograde and when you have to make a connection. You penetrate the proximal cap, you get in the subintimal space, you go retrograde, you penetrate the distal cap, you get into the subintimal space or extra plaque, as long as this is not a mode of failure. This is an opportunity of success, as was stated before. This is a transverse representation of the same cartoon. In the middle, you see what's left of the true lumen intraplaque, and then you see, pick your choice, left or right is the antegrade and retrograde wire. They're on the same space surrounded by the adventitia. That's the ideal situation where you want to be in order to make the connection and complete your retrograde case. So some simple steps: obtain bilateral guide access. This is mandatory. Perform dual injections in multiple views. Place antegrade wire up to proximal cap of CTO. Retrograde wiring with long microcatheter. Retrograde wire escalation to get wire to the subintimal space near the proximal cap. The longer the CTO, the more likely is that you're going to end up using the subintimal space. Advance antegrade wire into the subintimal space with a knuckle. Antegrade balloon advanced inside the subintimal space and inflated. Advance retrograde wire into the true lumen of proximal vessel. Then either snare or a wire directly into the guide. Advanced microcatheter into the antegrade guide. Swap retrograde guide wire for an externalization specialty guide wire like the RG3 or the R350, and then perform routine PCI in an antegrade fashion. I usually like to complete my cases through the externalized because you have a lot of support. There are situations, as the one that I'm going to show you, that was not possible, but also the patient cannot tolerate it because of ischemia or a lot of tension in the heart. Reasons for difficult reverse card, which is where we're going to focus our talk, is vessel tortuosity, calcification, undersized antegrade balloons, balloon dilatation not performed all the way back into the true lumen proximally. You really want to create the whole tunnel back to the proximal true lumen. Knuckles have caused big hematomas. Reverse card performed not in the optimal position, and I think this is something that we tend to realize more and more as we use intravascular ultrasound. You want to really try to make the connection at a safe spot, which is usually a straight part of the vessel, and also where your antegrade and retrograde gear are closest to one another to avoid going into larger balloons with potential increasing the risk of a perforation. And very similar, antegrade and retrograde wires are not in the subintimal space, which is the optimal position to make your reverse cart. And this is a recently published study in Eurointervention from Colombia and Akiko and our team, where you see the 4 patterns of antegrade, and retrograde wires, and just focus on the right. The most difficult connection is you have the antegrade wire in the subintimal space and the retrograde wire intraplaque. This is a situation where there was a need to redirect the wires and create different planes in order to make the connection. I'm going to share with you, a case I did recently, and I hope that you will find some interesting points here because we had to do a lot of problem solving. So this is the left shot, and you see, to me, this is a very ambiguous proximal cap. I have no idea how tortuous the vessel is. There are a lot of bridging collaterals. There are a lot of branches there. Back to the question, do we always start antegrade or retrograde? Plus, I had issues with guide support. Even if these cases were not CTOs, these patients are vasculopaths, so he had a horrible aorta. A good trick here is to put even longer sheaths than the 45 in order to get better control of your guides and better support. We have very good retrograde options here through the septals. And here you see that we chose the first septal. This is usually the one I try first. It was not difficult to cross. You see that this is the wire is actually towards the posterolateral. It was very easy to advance the microcatheter, which is this case is a caravel, and will become relevant as the case goes on. We had just to advance the microcatheter and then rewire into the true lumen in the AV groove RCA. A technique that I use more and more and think is underutilized is a distal tip injection. It gives you better visualization and more details as to the anatomy of the distal cap. You just have to be careful not to be subintimal because it's not the end of the world, but you can actually extend it if you inject too powerfully distally, and then that will be the end of your case. So this is something that I strongly recommend. You'll save yourself a lot of trouble. You see here branches that you could not see with the dual injections from the guides. And here is the problem that I was talking to you about, problem solving number one. The caravel crossed easily, but it gives you no support. So you get to a position where you're at the distal cap, and then as you're trying to either penetrate or form a knuckle, then you have nothing, you have no support. So the solution to that is to just take it out, trap it, and then introduce something with a little bit bigger body. I think in this case it was an LP, if I was not mistaken. And this is why not every case should be started antegrade. I was really scared when I saw those knuckles forming there. I like to make this kind of pseudo-panoramic view to make sure that actually there is some dancing antegrade or retrograde, but this was clearly unanticipated. Just imagine trying to get a stiff penetrating or even steerable wire and try to figure out this proximal vessel tortuosity. The other issue that you see here is that the knuckles are huge. So where are you going to make the connection and how? So proximal cap ambiguity, I use the scratch and go, penetrating wire. I like to get into the wall of the diseased artery, advance the wire a little bit, flip it up, advance the microcatheter into the subintimal space, and then you will see as we do this, I'm sorry, maybe here you see the knuckle forming antegrade. Now we're in a much stronger position. We obviously also have a wire to increase the guide support in the conus branch. Again, you need to check in two projections, but the knuckle stays small, which is very important, which means it's in a confined space. And now we're ready to perform the reverse cart. Now we need to start ballooning. Where are we going to make the connection? Are we going to make it in the very tortuous segment there? I think this is, I think, dangerous. You will need very large balloons. It's going to be very difficult to steer the retrograde penetrating wire, and it's, I mean, you're looking for trouble. You're going to spend a lot of time, and you may end up with a perforation. So we decided to start ballooning and then get a guide extension into a little bit more favorable part of the vessel. You see it's straighter. Try to make your connection in a straight part where the knuckles are small, no big hematomas, where the antegrade and the retrograde wire are closer to one another. It took us a while to make the connection, but we were finally able to get our retrograde wire into the antegrade guide extension. Next step is to advance into the guide and then remove the wire that was a Gaia 3 that we used to make the connection. And then we thought we were done, but I don't know how many times you've seen that. I try to get the externalization wire you see here, and after a while, due to the extreme tortuosity, it would just not go. So where in the case we would have crossed, we thought we were done, we have a guide extension down, and I cannot externalize the wire. So we decided to use a tip-in technique, which I will show you here. It's actually much easier than it looks. It doesn't require too much skill. So essentially, you take an antegrade wire, and you wire into the retrograde guide. And here you see that it takes the course of the vessel. And then, to make a long story short, then it's just simple ballooning and stenting. This is a distal stent. Yeah, the patient was a Navy Yard worker. So he had asbestos. And then it's just stenting. And I just want to show you here the degree of the tortuosity of the vessel. And this is the final result. We didn't go for perfection. My fellow wanted, not my fellow, Amir wanted to do an IVUS. I said, I'm done with this case. It looks good. I'm not going to do anything more in that horrible bend there. It was a 4.0 stent. And obviously at the end, always check the donor vessel to make sure that there's no injury. Thank you very much.
Thank you, Dimitri. Kate, what are the things you struggle with retrograde? What are a tip and trick, one of the common problems?
I think one of the things I've definitely had to change over the last couple of years is moving that base of operations, as you referred to it, sooner, that you get, sort of wedded to the idea that I've worked so hard to get my retrograde microcatheter up, that the idea of coming back.
To see, like Dimitri pointed out on his talk, you can see whether both wires are true or if they're in different spaces, because that oftentimes can help you in your decision making. And then with ballooning, like Kate said, traditionally we've always kind of gone to bigger and bigger balloons, but I like to use a guide extender and move that up and down to get different spaces. And then finally, if my antegrade wire is intraplaque and my retrograde wire is in a subintimal space, I've been going to earlier use of scoring balloons or cutting balloons to kind of create some fissures. And you don't have to go to a really big balloon, and it can be done real safely to kind of facilitate your retrograde reentry.
Okay, Paul, you get the last word on this. Any advice for people learning retrogrades? What do you do with challenging situations?
With challenging situations?
Yeah, I mean, what's your tip and trick? You've heard a lot of people's comments about how to do this. Anything to add to that?
I would say is do your homework up front. I spend about 30 minutes per case studying, figuring out which retrograde option to go down. I know option 1, 2, 3, and 4 in my head. And then after that, the most challenging part for me about retrograde is actually making the connection. It's not necessarily getting there. And all the tips and tricks that everybody else said in terms of moving the base, bigger balloons, scoring balloon, IVUS guided is useful as well.
Dimitri, final comment?
Yes, I just wanted to make a final comment about the safety of the procedure. Bad things in retrogrades, as in all CTOs, happens when you pull, not when you push. So first of all, always you have to have your collateral covered with a microcatheter, otherwise you're going to have collateral injury, and even in the septum it can be sometimes catastrophic. But also when you remove your gear up and down, especially the microcatheter, to create space to work, make sure you disengage the donor guide and keep it outside, otherwise you're going to have a big dissection in the donor vessel, and that can be catastrophic. Thank you very much.
Dimitri, regarding this, we wrote that chapter for the next upcoming book on retrograde. Maybe you didn't see that. We added something that I think it should be implemented for safety. So whenever we're doing retrograde nowadays, when we've externalized, what I do is I put the wire into the left sinus. So because when you're working with fellows and everything, it's easy to forget about the fact that if you pull on things that your guide can intubate. And actually, it's one way, very simple, to make sure that your guide will not deep in, is just drop a wire into your left sinus, and then you do your work on your antegrade, on your externalized wire, and you don't have to worry anymore about your guide sucking in and dissecting the donor. So came out with this I want to share this with people because I've seen people adopting it, and I think it's one way to make the procedure safer.
Yes, and since we're talking about safety, I think also putting a safety wire down the donor vessel is a very good idea as well.
Right.
Thank you.
And I'll end with history because I'm the old guy. So when we talk about subintimal stenting, remember the very original description of retrograde was controlled antegrade and retrograde subintimal tracking by Osamu Kata. So the first description of subintimal stenting was from the Japanese. So it's interesting how we change potentially some of our thought processes over time. With that, let's talk about going from trying to be reasonable and thoughtful to trying to push the envelope, with Kate Kearney talking about subintimal plaque modification and STAR.
Yeah, you can imagine that this topic makes some of those folks queasy, but something we've had a fair bit of practice with and a lot to learn. And I think partly some of the uncertainties have made it a bit confusing, so we'll try to clarify a little bit of that. So there's actually several euphemisms for this procedure. Our favorite is failing with style, but we often call it the investment procedure. But I think all of these are good ways to remember that, one, we can always make things worse. So when we're in these cases and you've been going for several hours and you failed a few techniques, that's often not the time to push the envelope. And these are by definition chronic stable disease patients, and usually coming back with a new plan after studying things another day is quite helpful. But I do find that in many of those, we're motivated to do something that can facilitate our success the next time. And so sort of think of these two items as part of a spectrum that we'll go through. But subintimal plaque modification is really that we have found ourselves in the subintimal or extra plaque space across the proximal cap, and we want to do something to modify that. So actually just some external cap crush, something ballooning around in that area, or even the lesion of the body, the body of the lesion as well, can be helpful to modify that and to facilitate your entry next time. In those cases, we're not stenting clearly because we don't have outflow and we're in the subintimal space. Now, subintimal tracking and reentry is one where we actually do have reentry into the distal true lumen, and so we do angioplasty across that segment to facilitate flow, but in most of these cases, we are still deferring stenting because of those diffuse dissection planes. We'll go through that. And the idea is to have a follow-up procedure typically in about 8 to 12 weeks so that you do have more time for healing in that process in the dissection planes. And the more flow we have, the more those dissection planes will actually communicate and can facilitate your success the next time, as shown in some of the data that Manos presented earlier. So I think if we're thinking about these on the spectrum, the original STAR were just advancing a knuckled jacketed wire, really a number of different wires that would re-enter basically at random in the distal vessel. That was highly unpredictable, usually long segments of dissections, and because we're shearing off many of the side branches and have poor outflow, the stenting that was originally done in those had a high failure rate long term, so it was clearly not a durable result, and we moved away from that. Kind of the adage of mini-STAR came about of using specialty wires that are made to have a rapid transition, so they form a small knuckle, probably re-enter sooner, and so the idea is that if we get more outflow branches that we can facilitate that success. And then of course, again, the subintimal plaque modification is really that we are not ballooning to get outflow, but that we're just doing some work at the body of the lesion. I think both of these can be helpful. There is some data on that, I mean, that's limited, but if we look at the registries we have in open CTO, patients actually did have improvement in their Seattle Angiogram questionnaires after subintimal plaque modification versus just a regular failed CTO without that. And recanalization was the largest predictor. So that sort of argues that there is some physiologic basis that wasn't purely sort of us telling the patient what happened in a placebo effect. And part of that is for reasons we don't understand. You can leave the coronary looking like hot garbage at the end of the case, but you come back for that in the completion procedure, and actually there can be flow in some of those because of the way flow facilitates the dissection plane healing. We also saw this in Progress CTO, where about 15% of patients underwent subintimal plaque modification, and waiting a couple of months from the index to the completion procedure was the highest predictor of success when they looked at that. So I think those are some of the things that we're learning, is that waiting is better and probably a little bit longer. When to consider this is really the cases where your other option is a very risky epicardial collateral that we figure, if I really am not sure that this particular case is worth that, this particular lesion, this substrate indication, whatever, that this is a way to maybe avoid that. And also to just help us decrease the risk associated with some of those when they really are not favorable for intervention retrograde. It also helps us to decrease our failure when the options are very limited in some of these patients with highly ambiguous vessels. And that's limiting other options and poor retrograde options in particular. And in particular, if a side branch CTO is the target vessel. So for a smaller OM territory that, we often joke we're waiting for Tim Henry to run the trial where we inject alcohol to these little branches so they stop causing people angina. The really small territory that, you're not really after for any other reason except that this patient keeps coming back with symptoms that clearly relate to that. And this gives us a good way to help facilitate improvement of that without taking on those higher risk epicardials in particular. So when we should particularly avoid star, I think we have to think about what are you doing to your downstream target vessel. And so if you're getting too close to your distal target, then we need to consider that maybe we should just do that proximal cap modification and avoid those distal dissection planes. So being mindful of that, of how far to carry it. Clearly, if we can safely use ADR or retrograde issues to solve this issue, and in particular, if we're having difficulty puncturing the proximal cap. So I myself, I think, taking some of this data from open CTO and being mindful of epicardial collaterals, sometimes we're too focused on avoiding that and trying to get antegrade to star in an OM CTO, for instance, when some of those epicardials were actually a safer way to solve the ambiguity, as Dimitri just nicely outlined. So I think getting on to how to actually do this, it's a relatively easy technique to master, but it takes a little bit of kind of experience in just sort of navigating a few issues. But largely, you're just simply finding yourself in the subintimal or extra plaque space. You're advancing a microcatheter to support the wire, and then without torquing, or at least not significantly, we just advance that knuckle jacketed wire. So this is a small knuckle advancing. You can see it sort of accelerates and shrinks. It's already starting pretty small, and that gives you an indication of the size of the vessel somewhat as well. In general, we're using larger knuckles, more proximal to the vessel in a lot of these ADR techniques. I'll show an example of that. So just a few examples. This gentleman was someone we took to the lab shortly after finishing fellowship for me. And so, kind of thinking he's 54, he's diabetic, he also has CKD, we have a lot of contrast limitations. We've already treated the right as a staged procedure. So coming into looking at his LED here, I really wanted to salvage his diagonal that was nearby, since that's filling retrograde. Had some difficulty with both retrograde and antegrade options. Going right to left through the septal is a little dependable for me. I did this collateral tip injection on the bottom right, and that made me kind of want to puke the way that blush looked. I didn't see anything that I really liked there. And moving on quickly to ADR, I still had some hematoma issues there and really didn't want to extend past that diag and wasn't as confident about rescuing that after. So rightly or wrongly, I was fixated on that, but figure I've used some contrast trying to go retrograde, do some contrast trying to do ADR, so I'm out of that with him and his kidney failure. And so just to rescue the diag that we had seen earlier, just did a star into that diag, do a little bit of balloon angioplasty at that, near the proximal cap for the LAD, after de-escalating to a workhorse wire, and that's the final result, is nothing to look at. We see some dissection into the diag and a little bit of outflow. But when we brought him back 2 months later, it still doesn't look great, but we actually were able to wire both of those branches, including the LAD, just with workhorse wires, and so really our only issue was doing some bifurcation PCI. So, but 50%, based on the data, 50% of the time it works every time. The other half, it's really not so dependable. So I think part of it is from a mental standpoint, when we come back, we hope they're open. Sometimes the patient says they feel pretty decent, and then you get there and it's closed. So I think we have to rapidly kind of switch strategies, and usually that's a retrograde salvage maneuver. But this is another case where it's a 70-year-old gentleman come from out of state, class 3 angina, and occluded graft to his occluded native RCA. So we actually had a guest operator was there. We tried retrograde through the septals. We took a look at what the IMA was filling. We have poor visualization. So we eventually decided to try the occluded graft as well, but that was subintimal among entry. So having failed those things, we decided we're going to just go to our antegrade techniques and set up for ADR. There is some knuckle management that has nuances. So in this case, in the REO view, even our big knuckle, so the big knuckles are typically a jacketed wire like a Pilot 200 or radar wire, a gladius, things like that are going to form larger knuckles. And sometimes they're harder to see because you're off the radiopig segment. But when we actually cine, you can see the knuckles going into a marginal. So we're worried about perfing that. So we had to do some redirection to get out of that. Once our larger knuckle is around the main area with those branches, then we swapped out for a smaller knuckle wire, and so those are typically Gladius Mongo has a rapid transition designed to have a smaller knuckle and re-enter earlier. Fielder XT is one that's nice to and slick to use for these as well. So we did that to set up for ADR, but unfortunately failed that, had poor visualization, kind of a poor distal target, and so just advanced the knuckle. And I think in these it's important to know when it is small and you're unsure where you are, if you have any visualization, to be sure that we're actually in the target branch that we want, not a very small side branch is helpful before ballooning. In terms of how to put these together, I think this is where practicing imaging all the time is really helpful, because sometimes in these very small distal targets, it's actually difficult to tell by IVUS if you're in the true lumen. So I think putting these back together, that's very
very useful, both in terms of how far we need to balloon in the index procedure and also for the stage procedure. So again, angiogram isn't much to look at, but does facilitate flow and hopefully gives us better options when we bring him back in a couple of months. So I think in conclusion, when considering subintimal plaque modification, that proximal cap modification may increase your downstream success and is a way to kind of build on all the work that you've done that first time, take advantage of the contrast and time that you've already invested. And importantly, symptoms actually can improve, and as we've already discussed, in a lot of these patients, that's really what we're after. I think also importantly, STAR is a teachable bailout technique, and so a lot of people have kind of looked to this as a way to manage a guide dissection in a right or an issue with that during PCI, that if the patient's really having an acute issue, this is a relatively easy technique to learn relative to ADR and some other things that we've all spent a lot of time trying to get better at. But we need to be mindful of your distal reentry and what those downstream consequences are. Finally, I think the durability of this STAR result is quite uncertain when you have diffuse distal dissection planes, so being mindful about our case selection is important, and we have a lot to learn from that, including a trial where we're looking at the timing of when to bring people back. But clearly, to some component, both outflow and DAPT are key, I think, to improving those long-term results. Thank you.
All right. Thank you, Kate. All right. A couple of cleaning house things, and then I'm going to take old guy privilege, or old person privilege. So today's evening symposia and reception, they're from 5 to 6:30 is a fellow welcome reception. It's in the Mineral Hall foyer, and it's sponsored by Gore. From 6:30 to 9:30, there's an innovation summit and a Shark Tank competition. You see a good friend of mine, Mark Turco, is going to be there doing it. That's in the Centennial F, G, and H, and is sponsored by CVI. And remember, that's us, the meeting. That's Monis's meeting.
No, this is the room.
This is the room. Oh, it's Monis's people and the meeting and the room. It's all the same place. And then tomorrow night is the attendee and faculty reception from 9 to 12 in the former Saint restaurant on the first floor. I want to leave everybody with a couple of thoughts before they walk out. Number one, success is a bad metric to follow, because success is about you and about your ego. What you really want to look at is skill set development, because anybody can make their success rate whatever they want to be by cherry picking. What you really want to look at, are you building skill sets? If you look at all the techniques, which one do you not know very well? And how are you going to figure out how to get better at it? And the reason I say that is, I have a rule of 10, which is you may never critique a technology, a device, or a technique unless you've done it at least 10 times yourself. Because if you haven't done it, all you're doing is saying, I'm refusing to learn it, so you're going to make fun of it. We just saw that at a meeting we put on. A gentleman was making fun of Basilica who had actually never done Basilica. So don't make fun of things you don't know how to do. Learn them, understand them, get good at them, then you can critique whether they're good or bad, which means sometimes you need to get coaches to come in and help you so that you can do them well at an effective level. And I think with that, Dimitri, unless you have any final comments, I'm going to get us out on time because the boss is in the room and I want to make sure we stay timely. So, Dimitri, any last comments?
No. Thank you very much for attending. I hope you found it useful and enjoy the rest of the evening. Thank you.